Did you know that even after just one shoulder dislocation, a really significant number of patients already show signs of bone loss?
That's right. There's a study by Griffith and colleagues, quite striking, really. They found glenoid bone loss that's on the socket in 41% of cases after a first-time dislocation.
41%. Wow. And presumably it gets worse if it happens again.
Oh, dramatically worse. That same study found the rate jumped to 86% in patients with recurrent dislocations. And other research backs this up, showing significant bone defects on both sides of the joint, the socket and the ball, becoming almost the norm in those chronic cases.
And for younger, active people,
Yep.
that risk of it happening again, it's incredibly high, isn't it?
Disturbingly high. Rates up to 96% recurrence been reported for young patients after a first traumatic dislocation. It sets the stage for a cycle of instability.
So it begs the question, what happens when this common, painful injury just keeps coming back? When it becomes this recurring nightmare, causing complex problems that the usual straightforward fixes just can't seem to handle?
That's the crux of the issue we're exploring today.
Welcome to the Deep Dive. We're the show that aims to cut through the jargon and extract the really crucial insights from dense source material. Today, we are digging into the complexities of shoulder instability.
And we're drawing heavily on some very detailed clinical perspectives, particularly from the book Complex and Revision Problems in Shoulder Instability.
Exactly. Our focus isn't on a simple strain or first-time injury that gets better easily. We're navigating the much tougher terrain. Think significant bone damage, specific patient factors making things trickier, or situations where previous surgeries haven't quite worked out.
These are the scenarios that demand more advanced thinking, more sophisticated techniques.
We want to understand why those standard approaches sometimes fail and what the next level of solutions actually involves.
And exploring that intricate landscape requires a clear view of the evidence and the practicalities.
Which is why I'm delighted you're here to guide us. Your expertise in synthesizing this complex medical knowledge, connecting the dots between diagnosis, treatment, and importantly, long-term patient outcomes is exactly what we need.
Happy to be here and delve into it.
Right. Let's kick off with a quick rapid-fire round just to set the scene for our deep dive. 3 quick questions.
Fire away.
Okay, first one. When a shoulder keeps, popping out, what's the fundamental problem we need to consider beyond just tearing ligaments?
Well, while the ligaments in the capsule are definitely injured initially, the critical issue, especially with repeated instability, is often damage to the bone, specifically bone loss.
Bone loss.
Yes, either from the glenoid, the socket, or the humeral head, the ball. Losing that bone fundamentally changes the joint's shape and its mechanics. It makes it inherently less stable, irrespective of the soft tissues.
Okay, so bone loss is absolutely central. Second question. Why might an initial soft tissue repair, something like a Bankart repair, not be enough, especially for certain people?
The main reason they fail, quite often, is that the underlying bone loss wasn't fully appreciated or adequately addressed. If you're missing a significant chunk of bone from either side, just stitching the labrum back on doesn't restore the joint's structural integrity.
Makes sense.
And we know the risk factors for failure pretty well now, being young, playing high-demand contact sports, and critically having pre-existing bone defects, even seemingly small ones sometimes. These patients are much more likely to fail a simple soft tissue fix.
Right, those factors really flag who might need a more robust solution from the start. And final, rapid fire. In orthopedic terms, what makes a shoulder problem complex or needing revision?
Okay, so complex generally means your standard straightforward treatments probably won't work. This could be due to major bone loss, maybe the patient has other conditions like epilepsy or connective tissue disorder, or perhaps it's just a very unusual injury pattern.
And revision.
Revision means exactly what it sounds like. A previous surgery to stabilize the shoulder has failed. So now you're going back in. Operating on a joint that's already been surgically altered, likely still has underlying problems, perhaps scar tissue. It makes the second, or even third, attempt significantly more challenging.
That really clarifies the scope. Complex and revision. It's not the simple stuff.
Yeah.
Okay, let's settle in now for our first proper segment. Let's really unpack the anatomy first. Before anything goes wrong, how does a healthy shoulder stay stable? It has such incredible movement. How does it manage it?
It's a fascinating bit of biological engineering, actually. The shoulder cleverly uses different mechanisms depending on where the arm is.
Okay.
So in the mid-range of motion, think arm by your side, maybe slightly out in front, but not at the extremes. Stability mostly comes from non-ligamentous factors.
Like what?
Two main things. One is the negative intra-articular pressure. Basically, a suction or vacuum effect within the joint capsule helps hold the ball centered in the
A
socket.
vacuum seal, almost.
Kind of, yes. And the other is the concavity compression effect. This is where the rotator cuff muscles actively pull the humeral head, the ball, firmly into the concave glenoid socket. Like pressing a ball into a perfectly matched cup, the muscles provide the compression force.
Okay, so suction and muscle compression keep it centered during everyday movements. What about when you reach right up high or throw something? The extremes of motion.
That's when the passive structures take over, primarily the capsule ligamentous structures. The joint capsule itself and the thickened bands within it called the glenohumeral ligaments become taut.
They tighten up.
Exactly. They act like check reins, physically stopping the humeral head from sliding too far forward, backward, or downward on the glenoid. They're the end-range stabilizers.
It's quite elegant, really. Different systems for different jobs. Now let's bring it back to the injury. What actually happens to these structures during a traumatic anterior dislocation? It sounds quite violent.
Often is. A forceful anterior dislocation typically tears the structures at the front and bottom of the joint, the antero-inferior capsuloligamentus complex.
So ripping the capsule and ligaments there.
Yes, and when this involved the labrum tearing off the glenoid rim, that's what we commonly call a Bankart lesion. But, and this is a crucial point from our source material, this event frequently causes significant bone damage at the same time. It's not just soft tissue.
And that's where those startling statistics you mentioned right at the beginning come into play. It's not a rare thing for the bone to be damaged.
Not at all. The numbers really drive it home. Griffith's study again. 41% glenoid bone loss after just a first dislocation. It's happening right from the start in many cases.
Not just after years of problem.
Precisely. And after recurrent dislocations, that figure jumps to 86%. Other studies, like Piaseki's, found similarly high rates 49% to 89% with glenoid loss, and an incredible 70% to 100% incidence of damage to the humeral head, the ball, in recurring cases.
100%. Almost everyone with recurrent dislocations has damage on the ball side.
In that specific cohort, yes. And Wijajan and colleagues added another layer. They found that damage on both the glenoid and the humeral head occurred simultaneously in 54% of patients after just one traumatic anterior dislocation.
So bipolar bone loss, damage on both sides, is common even after the first time.
Yes, it forces us to think differently. This isn't just an occasional complication. Bone loss is a frequent, almost expected consequence of shoulder dislocation, especially if it happens more than once.
Those figures really do shift the perspective. It's not just about stitching up torn ligaments. You have to account for the missing bone. How does this bone loss actually look on the bones themselves? What forms does it take?
Good question. On the glenoid, the socket, you typically see two main patterns. One is erosion-type loss, which is more common in chronic instability. The bone gradually wears away over time.
It gets ground down.
Essentially, yes. The other is a fragment-type loss, often from the initial trauma, where the front rim of the glenoid actually fractures off. We often call this a bony Bankart lesion.
Okay, so wearing away or breaking off on the socket side. What about the humeral head, the ball?
When the humeral head is forced forwards out of the socket, the relatively sharp anterior rim of the glenoid impacts the softer bone on the back outer aspect of the humeral head. This creates a compression fracture, basically a dent or divot. That's the classic Hill-Sachs lesion, or HSL.
The Hill-Sachs lesion,
Right.
right? And when you have both the glenoid bone loss, whether it's erosion or a bony Bankart, and the Hill-Sachs lesion on the humeral head, what's that called?
That combination is termed bipolar bone loss. It signifies that you have these coupled bony problems on both the socket and the ball, and that inherently makes the instability problem much more complex to manage because you've lost structural support on both articulating surfaces.
Okay, bipolar bone loss, socket potentially chipped or worn down, ball with a dent. Now, there's a really key insight, particularly from researchers like DiGiacomo, that challenges how we used to think about the Hill-Sachs lesion. It suggests the size of that dent alone isn't the main issue. Is that right?
Absolutely. That was a pivotal shift in understanding. For years, we focused heavily on just measuring the depth and width of the Hill-Sachs lesion. Bigger lesion must be worse, right?
Seems logical.
But it turns out it's more nuanced. The real question isn't just how big is the dent, but will that dent physically engage or lock onto the front edge of the remaining glenoid during movement?
Ah, so it's about contact. Does the dent catch on the socket rim?
Exactly. If the Hill-Sachs lesion engages the rim, it levers the humeral head out of place, causing instability or apprehension. If it doesn't engage, even quite a large Hill-Sachs might not be the primary driver of the instability in that particular patient.
Okay, so engagement is key. How do we figure out if a particular Hill-Sachs lesion is likely to engage?
This is where the concept of the glenoid tract comes in. It's a brilliant way to conceptualize and, importantly, quantify the contact zone between the humeral head and the glenoid doing functional movements, especially those abduction and external rotation movements where dislocations often happen.
The track, like a pathway on the socket.
Precisely. Di Giacomo and his team proposed a method to calculate the width of this safe contact zone, this track. And, critically, the calculation accounts for any anterior glenoid bone loss.
How do they calculate it?
The formula they developed is 0.83 times the intact glenoid diameter minus the amount of the anterior glenoid bone defect.
Okay, so 0.83 times the socket width minus the bit that's missing. That gives you a number representing the track width. What do you do with that number?
You then measure the Hill-Sachs lesion on imaging, usually a CT scan. You look at where the medial edge, the inner edge of the Hill-Sachs lesion lies relative to that calculated glenoid track width.
Right.
If the medial edge of the Hill-Sachs falls medial to the glenoid tract, meaning it's further toward the center of the joint than the track extends, then that lesion is considered off track.
Off track. And that means?
It means it will engage the anterior glenoid rim during end range motion. It's a definite risk factor for instability. If the medial edge of the Hill-Sachs lies lateral to the calculated track, it's considered on track, and theoretically it shouldn't engage.
Okay. Off track equals engagement. Definite problem. On track means it should stay clear. Is it always that simple, or are on-track lesions completely safe?
Well, it's rarely that simple in biology. There are definitely nuances. And the source material highlights this. Even on-track lesions aren't always benign. They can still contribute to instability and lead to worse outcomes after a simple soft tissue repair if they are very large or very close to the edge of the track.
So location matters, even if it's technically on.
Yes. Yamamoto and colleagues introduced the idea of peripheral track lesions. These are on track, but they take up a large portion, maybe 75% or more, of the humeral head circumference where the track lies. Yang found a similar high occupancy ratio predicted recurrence. Others talk about near-track lesions, maybe within 8 millimeters of the track edge. These are also considered higher risk.
So the on-track, off-track distinction is the foundation, but you still need to look at the size and proximity to the edge for those on-track ones.
Exactly. The key takeaway is that assessing a Hill-Sachs lesion requires more than just measuring its size. You absolutely have to consider its relationship to the glenoid, particularly any bone loss there, using this glenoid tract concept and its refinements. That relationship is what truly determines the risk it poses.
That makes complete sense. It's about the interaction between the two damaged surfaces. And this deeper understanding directly explains why just fixing the soft tissues, like a standard Bankart repair, isn't always going to be enough.
Precisely. An arthroscopic Bankart repair works well when you have a simple labral tear and minimal or no significant bone loss. But if you've got, say, more than 15–20% glenoid bone loss or an engaging off-track Hill-Sachs lesion, just reattaching the labrum doesn't address the fundamental bony instability.
The foundation is still compromised.
Correct. And that's why the reported failure rates for Bankart repair alone can be quite high in some studies. Figures ranging from under 10% up to over 35% are cited. And significant bone loss is consistently identified as a major reason for those failures.
Which naturally led people to try and figure out before surgery who is likely to fail that standard repair, right? To identify those who need something more substantial.
Yes, exactly. This spurred the development of scoring systems, the most well-known probably being the Instability Severity Index score, or ISIS score.
ISIS score? What does that measure?
It combines several known risk factors for failure after a Bankart repair. Things like the patient's age younger is higher risk, their activity-level collision sports are higher risk, whether they had generalized ligament laxity or hyperlaxity, and crucially, the presence and extent of bone defects seen on imaging, both glenoid and humeral head.
So it quantifies the overall risk profile.
Precisely. The original recommendation based on the score was that if you scored above 6 points, you were considered high risk for Bankart failure, and a bony procedure like the Latarjet should be strongly considered instead.
Has that threshold changed?
There's been discussion and some studies suggesting that for certain very high-risk groups, perhaps even a lower threshold, maybe 4 points or even 3 points, might be more appropriate for recommending a bony procedure. It reflects a growing awareness that even combinations of seemingly moderate risk factors can lead to failure. The point is, we now have tools to help stratify patients and tailor the treatment rather than just doing a Bankart on everyone with instability.
So the ISIS score and the glenoid tract concept are guiding lights here, helping surgeons decide who needs more than just soft tissue work. And as you said, if you identify an off-track Hill-Sachs lesion, a Bankart repair alone is basically off the table.
That's the current thinking, yes. If you know that lesion is going to engage the rim, performing only a Bankart repair doesn't solve the mechanical problem. You need a procedure that either directly addresses the Hill-Sachs defect itself or alters the glenoid geometry to prevent that engagement. A Bankart doesn't do either of those things.
Okay, so this sets the stage perfectly. If that simple soft tissue fix isn't appropriate, particularly with bone loss or these engaging lesions, what are the surgical options? Let's move into our next segment and really explore these more advanced procedures.
Sounds good. There are several approaches depending on the specific problem.
Let's start with the Hill-Sachs lesion. If that's deemed the main issue needing direct attention, perhaps alongside a Bankart repair for the labrum, how can surgeons deal with that dent on the ball?
A common and effective technique is called remplissage. It's a French term, roughly meaning to fill.
Remplissage. Filling the defect. How does that work mechanically?
It's usually done arthroscopically at the same time as the Bankart repair. The surgeon identifies the Hill-Sachs defect on the back of the humeral head. Then they take the infraspinatus tendon, which is one of the rotator cuff tendons, and the underlying posterior capsule, and they suture or tendides that tissue directly into the bony defect.
Stitching the tendon into the dent.
Essentially, yes. The idea is that this soft tissue fills the hole. So when the arm moves into that vulnerable position of abduction and external rotation, where the Hill-Sachs would normally engage the glenoid rim, now this plug defect with the soft tissue makes contact instead. It prevents the bony locking mechanism. It effectively makes the defect extra-articular.
Ah, I see. So it acts like a soft bumper, preventing the bone-on-bone clash. What do the results look like when remplissage is added? Does it actually reduce the risk of dislocation?
Yes, the data is quite compelling. Adding remplissage to a Bankart repair has been shown to significantly lower recurrence rates compared to doing the Bankart alone, particularly in patients selected appropriately.
How much lower?
Well, overall recurrence rates with the combined procedure are reported as low as 4% in some series. But looking at studies that directly compared, the differences are stark. Our source material cites comparisons like 2.1% recurrence with remplissage versus 9.3% without, 1.8% versus 11%, 5% versus 30%, even 13% versus 47% in another group. The pattern is consistent. It provides a clear protective benefit against repeat instability.
Those are really significant reductions in recurrence. Does the stitched-in tissue actually heal well into the bone defect?
Yes, healing rates appear to be very good. Studies using MRI or second-look arthroscopy have shown integration of the tendides tissue into the Hill-Sachs defect in the range of 85% to 100% at follow-up. And encouragingly, longer-term studies haven't shown major concerning changes in that tissue, suggesting it's biologically well tolerated.
It sounds effective. Who is it typically recommended for now? Have the indications changed over time?
They certainly have broadened. Initially, remplissage was mainly reserved for those definite off-track Hill-Sachs lesions, the ones clearly engaging. However, its use has expanded quite a bit.
In what way?
It's now often considered even for on-track lesions if other factors put the patient at high risk of recurrence, young age, collision sports, maybe borderline bone loss. And importantly, it's being used increasingly for patients with what's termed subcritical glenoid bone loss, usually defined as between maybe 15% and 25%.
Why in that group specifically?
Because studies showed that in this subcritical bone loss group, doing a Bankart plus remplissage significantly reduced the failure rate compared to just doing a Bankart alone. It seems to add stability even when the primary issue isn't necessarily an engaging HSL, but rather borderline glenoid deficiency.
So it's becoming a tool for managing moderate risks.
To some extent, yes. Some surgeons referenced in our source material now advocate considering Bankart plus remplissage for nearly all young active patients with less than, say, 15–20% glenoid bone loss, almost irrespective of the glenoid tract calculation. They might reserve an isolated Bankart repair primarily for perhaps older, 25, lower demand patients experiencing their first dislocation with minimal bone loss. So the trend is definitely towards using remplissage more broadly in high-risk patients.
That's a really interesting evolution in practice. Okay, so remplissage deals with the humeral head side, the HSL, or helps bolster stability in borderline glenoid loss. But what if the glenoid bone loss is more substantial, say clearly over 20% or 25%? Is filling the HSL enough then?
No, probably not. Once you get into significant anterior glenoid bone deficiency, simply addressing the humeral head defect or the labrum usually isn't sufficient. The socket itself is too shallow, too unstable. In these cases, you need to physically reconstruct the missing part of the glenoid using a bone graft.
Right, replacing the lost bone. Has the threshold for deciding you need a bone graft changed?
Yes, it has tended to decrease over time, especially for high-risk individuals. Historically, the threshold might have been cited as 20% or 25% glenoid bone loss. Now, many surgeons will consider a bony reconstruction for defects over 15–20% and sometimes even lower, perhaps around 13.5–15% if the patient is very high risk, young collision athlete, or if it's a revision surgery after a failed Bankart. Subcritical bone loss itself is now recognized as a significant risk factor.
Okay, so the bar for needing a bony fix is getting lower. Where does the actual bone for the graft come from?
There are two main sources, autograft and allograft. Autograft means using the patient's own bone. The most common place to take it from for glenoid reconstruction is the iliac crest, the top part of the hip bone.
Taking it from the hip. Are there other spots?
Yes, sometimes bone can be harvested from the distal clavicle, the end of the collarbone, or parts of the scapula itself, like the scapular spine. The alternative is allograft.
Allograft meaning donor bone.
Exactly. Bone from a tissue bank, which has been processed and sterilized. Common allograft sources used for the glenoid include the distal tibia, the lower end of the shin bone, parts of the femoral head, the ball of the hip joint, or even a donor humeral head.
Is any particular type of graft highlighted as being especially suitable for rebuilding the glenoid?
The distal tibial osteoarticular allograft gets mentioned quite positively in the source material.
Why that one specifically?
Several reasons. Its natural shape often matches the curvature of the glenoid quite well. It's known to be dense, strong bone, which is good for holding screws securely. But perhaps most importantly, it comes with its own layer of articular cartilage intact.
Ah, so it rebuilds not just the bone, but the smooth joint surface, too.
Precisely. That allows for a more anatomical reconstruction, which theoretically might lead to better long-term joint health and potentially less arthritis down the line compared to using a graft that's just bare bone. Clinical results reported are generally good, with high healing rates around 89% cited and relatively low rates of the graft shrinking or resorbing over time, maybe around 3%.
That cartilage surface does sound like a big advantage. What are the general pros and cons of using donor bone, the allograft, versus the patient's own bone, the autograft?
The main advantage of allograft is avoiding donor site morbidity. You don't have to make a separate incision and take bone from the patient's hip or elsewhere, which avoids the pain, potential nerve issues, or other complications associated with that harvest site.
Makes sense.
And specifically for the distal tibial allograft, you get that cartilage surface, good bone stock, and it can often be shaped to fill quite large defects. The disadvantages? Well, allografts are more expensive. There can sometimes be issues with availability. There's an extremely small theoretical risk of disease transmission, though screening and processing methods are very rigorous now. And the surgical technique for implanting an allograft, especially an osteoarticular one, can be technically quite demanding.
Right, technical complexity is a factor. Okay, moving on from free bone grafts, perhaps the most famous bony procedure for shoulder instability is the Letarjet. It seems like a real workhorse for these complex cases. Can you break down what the Letarjet procedure actually involves?
Certainly. The Letarjet procedure is named after Michel Letarjet, the French surgeon who described it. It involves taking a specific piece of bone from the patient's own shoulder blade, the scapula called the coracoid process, along with the tendons that attach to it, and transferring this whole unit to the front lower edge of the glenoid socket.
So, moving a piece of bone from one part of the shoulder blade to the rim of the socket. Why that specific piece? How does it stabilize the shoulder?
It provides stability through what's famously known as the triple blocking effect. It's quite clever.
Triple effect. What are the three parts?
Okay, first, the bone block itself. Transferring the coracoid bone physically extends the glenoid surface area, replacing the missing bone and deepening the socket at the front. That's the direct bony block.
Right, just making the socket bigger.
Second, the tendons attached to the coracoid, the conjoint tendon, which is formed by the short head of the biceps and the coracobrachialis muscle, are transferred along with the bone. They end up lying across the front of the shoulder joint. When the arm is moved into vulnerable positions like abduction and external rotation, these muscles contract, and the tendon acts like a dynamic sling, actively resisting the humeral head from sliding forward.
A dynamic sling. Active muscle support. That's clever.
It is. And third, the procedure also has a tenodesis effect. Transferring the coracoid and its tendon effectively reinforces the often stretched out or damaged antero-inferior joint capsule. So you get bony augmentation, a dynamic muscular sling, and capsular reinforcement all in one. It's a powerful combination.
That triple effect makes sense why it's so effective. When is Letarjet the go-to procedure, and when might it not be suitable?
The primary indication is significant anterior glenoid bone loss, typically over that 15–20% threshold we discussed, depending on the patient. It's also very commonly used for revision surgery after a failed Bankart repair, especially if bone loss was the reason for failure or has developed since.
And contraindications.
Well, if the bone loss is absolutely massive, perhaps beyond what the coracoid graft can reasonably reconstruct, although there are technical modifications like the congruent arc technique for larger defects, these might carry slightly higher risks. Significant instability in other directions, like posterior instability, might also be a relative contraindication or require additional procedures.
You mentioned techniques. Can this be done arthroscopically, minimally invasively, or is it typically an open operation?
It can be done both ways. Traditionally, it was an open procedure requiring a larger incision, but over the last couple of decades, techniques for performing the Letarjet arthroscopically through keyhole surgery have become well established.
How did the results compare? Open versus arthroscopic.
Both approaches have demonstrated excellent results in terms of restoring stability and function, with low rates of recurrent dislocation when performed well. The reported recurrence rates after Letarjet are generally low figures, like 4% at 5 years, maybe up to 11% at 10 years are cited. One large series even reported just 1% recurrence.
That's impressively stable.
It is. And while overall complication rates reported in the literature can seem broad, ranging from 6% up to nearly 24% in the hands of surgeons who do a lot of these procedures, the rates tend to be much lower, often in the 4–7% range. It's technically demanding either way.
You mentioned recurrence is low, but when it does happen after Letarjet, is there a typical time frame?
Yes, interestingly, most recurrences following a Letarjet procedure tend to happen relatively early, usually within the first year or two after surgery. Compared to Bankart repair, though, Letarjet generally provides superior long-term stability, especially in those high-risk patients.
And for athletes, that's often the key group needing this. What about getting back to sport after a Letarjet?
Return to sport rates are consistently high, which is a major advantage and why it's often favored for athletes, particularly those in contact or collision sports. The source material suggests overall return rates up to 88%, with around 72% managing to get back to their pre-injury level of competition.
That's very encouraging for athletes facing this.
Absolutely. That combination of high stability and high return to sport rates makes it a very appealing option for that population, even though it's a more complex operation than a simple Bankart.
Okay, so excellent stability, good return to sport, but it is more complex. What are the potential downsides or complications specific to the Letarjet procedure?
Well, the main conceptual disadvantage is that it's inherently non-anatomical. You're changing the shoulder's natural structure by adding bone and moving tendons. This can potentially make any future surgery, should it be needed, more difficult.
Right, operating on altered anatomy.
Exactly. Also, the bone graft itself, the coracoid, doesn't have articular cartilage on the surface that faces the humeral head. There's a theoretical concern, though it's debated, that this bone-on-cartilage articulation could potentially increase the risk of developing osteoarthritis over the very long term.
And other complications.
Specific complications can include problems with the graft itself, putting it in the wrong position, it not healing to the glenoid, non-union, or shrinking over time, resorption. The screws used for fixation can cause issues if they're too long, too short, break, or irritate tissues. Persistent instability can still occur if the underlying issues weren't fully addressed. Infection is a risk, as with any surgery. And nerve injuries, while uncommon, are a known potential complication due to the location of the dissection.
Let's pause on those specific challenges for a moment. Our source material delves into certain patient groups where instability is particularly complex. You mentioned patients with seizure disorders earlier. How do seizures complicate shoulder instability? It seems like a difficult combination.
It really is, and it's a crucial group to consider. Patients with epilepsy, or PWE, can have incredibly forceful, uncontrolled muscle contractions during seizures. These contractions can be strong enough to actually dislocate the shoulder or even cause fractures around the joint.
So the seizure itself causes the dislocation.
Yes, it can be the primary mechanism of injury or re-injury. Historically, posterior dislocations were often associated with seizures, perhaps due to typical arm positioning, but actually both anterior and posterior dislocations are well documented. The forces are just overwhelming. Furthermore, repeated seizures, especially if poorly controlled and perhaps in younger patients whose bones are still developing, might lead to gradual bony changes over time, like increased retroversion, backward tilt, of the glenoid socket, further predisposing to instability.
Wow. So the underlying condition directly impacts the joint mechanics and risk. How does this change the treatment approach?
It adds significant complexity. Trying non-operative management is often less successful if seizure control isn't optimal. When considering surgery, achieving good control of the seizure disorder first is absolutely paramount,
Why is that so critical?
because having a major seizure soon after surgery could easily disrupt the repair or reconstruction. Many recommend aiming for a seizure-free period, perhaps at least 6 months, before undertaking elective stabilization surgery to minimize this risk.
And the type of surgery, does it influence that too?
Yes, strongly. Given the potential for massive uncontrolled forces during a seizure, relying solely on a soft tissue repair is often considered too risky. Bony stabilization procedures, like the Lafayette for anterior instability, or perhaps bone grafting for posterior defects, are frequently favored. They provide more robust structural stability that's less likely to be overcome by muscle contraction. The absolute key, though, is multidisciplinary care. Close collaboration between the orthopedic surgeon and the neurologist managing the epilepsy is essential.
That integrated approach sounds vital. What about the other challenging group mentioned, patients with hyperlaxity, maybe conditions like Ehlers-Danlos syndrome where ligaments are naturally loose?
Yes, managing instability and generalized hyperlaxity is a different kind of challenge. Here, the core problem isn't usually a single traumatic tear, but rather the inherent stretchiness of all the connective tissues.
So surgery might not be the first step.
Absolutely not. The initial approach, and often the mainstay of treatment, is intensive non-operative management. This means a prolonged course of dedicated physical therapy, often lasting 3 to 6 months or even longer.
What's the focus of the physio?
It's all about building dynamic stability, strengthening the muscles around the shoulder, the rotator cuff, the muscles that control the scapula, and improving proprioception, which is the joint sense of its position in space. The aim is to use active muscle control to compensate for the loose, passive ligaments and capsule.
Trying to make the muscles do the stabilizing work the ligaments can't.
Exactly.
And if that extensive physio still isn't enough, what are the surgical options then?
If surgery becomes necessary, it's usually focused on tightening the overly loose joint capsule. For patients with true multidirectional instability, where the shoulder feels loose in all directions, the typical procedure is an arthroscopic pancapsular application.
Encapsular application. Tightening the whole capsule.
Yes, essentially gathering up and suturing the redundant capsule from all sides to reduce the joint volume and improve stability. If the hyperlaxity is present, but the main problem is still primarily anterior instability, sometimes surgeons might perform a Bankart repair combined with a procedure to augment or tighten the subscapularis tendon at the front.
What's the big challenge when operating on hyperlax patients?
The challenge is finding the sweet spot. You need to tighten things enough to provide stability, but because their tissues are inherently stretchy, it's easy to over-tighten and leave them with significant functionally limiting stiffness. It's a very delicate balancing act.
Right, so we've journeyed from the basic mechanics through to advanced procedures like remplissage and letarget, tackled bone loss, and considered these specific patient complexities. But as we know, surgery isn't always the final chapter, and things can go wrong. Let's pivot now to look at complications, the challenges of revision surgery, and the longer-term outlook for these shoulders.
Indeed, understanding potential failures and complications is crucial.
You mentioned earlier that failure after a standard Bankart repair often links back to unaddressed bone loss. Is there a characteristic way the glenoid bone fails after that kind of repair, especially with modern anchor techniques?
Yes, there's a specific pattern that's been described, particularly following arthroscopic Bankart repairs, using suture anchors drilled into the bone. It's sometimes called the postage stamp fracture.
Postage stamp fracture. Why that name?
Because if the shoulder redislocates after such a repair, especially if there was already some bone loss, the anterior rim of the glenoid can fracture right through the holes where the anchors were placed. It creates this fragmented, almost perforated look along the rim, like the edge of a sheet of postage stamps.
Ah, I see. The ankle holes become weak points.
Exactly. It suggests the bone quality wasn't sufficient to withstand the forces, potentially exacerbated by the underlying bone loss, and maybe even related to the stress concentration caused by the anchors themselves. Their placement, size, or material might play a role.
That sounds like it would make going back in for revision surgery even trickier. When a Bankart does fail, how do surgeons decide what to do next? Try another Bankart or switch to something like a Letarjet?
That's a really critical decision. If the primary Bankert failed clearly because of significant bone loss that wasn't addressed initially, or if the patient has multiple high-risk factors like being a young collision athlete, then simply repeating the Bankart repair is very unlikely to succeed. It's often considered contraindicated in those situations.
So Letarjet becomes the main option.
In most cases, a failed Bankart repair, yes, especially if there's documented bone loss, either initially missed or developed over time, or the patient falls into that high-risk category. A bony procedure like the Letarjet or sometimes a bone grafting technique is generally the preferred revision strategy.
How do the outcomes compare revising with another Bankart versus revising with a Letarjet?
The source material suggests that, generally, revising a failed Bankart with a Letarjet leads to better functional scores, better stability, and higher rates of return to sport compared to attempting a revision Bankart. However,
There's always a however.
there is. Revision Letarjet doing a Letarjet after a previous failed surgery can be technically more demanding than doing a Letarjet as the first operation. It might be associated with slightly higher complication rates, potentially more post-operative pain, and sometimes greater loss of external rotation compared to a primary Letarjet. So while it's often the better option for stability, it's not without its own challenges.
Revision surgery is just inherently more complex. What about failures of the bony procedures themselves? Can Letarjet or bone grafts fail too?
Oh, absolutely. They can fail for various reasons.
Yeah.
Technical issues during the initial surgery are one cause. Maybe the graft wasn't sized correctly, or it was put in the wrong position, or the screws used for fixation weren't quite right, leading to instability or non-healing.
So surgical technique is paramount.
Hugely important. Other causes can include failing to address other problems at the same time, like significant soft tissue damage elsewhere, or a large Hill-Sachs lesion that also needed attention. Infection is always a risk. Hardware can fail or break. And specific to bone grafts, they can sometimes fail to heal to the patient's bone, non-union, or they can gradually resorb or shrink over time.
Graft resorption. The bone graft actually disappearing. That sounds like a major problem for long-term stability. How often does that happen?
It is a concern, particularly perhaps more with allografts than autografts, although it can occur with both. The reported rates vary quite a bit in the literature, but significant resorption, say losing more than 25% of the graft volumes, definitely described. It seems less common now with modern techniques and fixation, but it's a known potential long-term complication.
What causes the graft to resorb?
It's often thought to be related to mechanical factors. If the graft isn't positioned perfectly flush or isn't held absolutely rigidly with a fixation, any tiny movement or micromotion at the graft-host interface can hinder proper bone healing and potentially trigger resorption. The biological properties of the graft type might also play a role, with some suggesting living autograft cells might make it less prone to resorption than processed allograft. Really meticulous surgical technique and achieving solid fixation are key to minimizing the risk.
Beyond the surgery just not working to stabilize the shoulder, what other common complications can pop up after these complex instability procedures?
Well, nerve injury is one that always needs careful consideration. Fortunately, permanent nerve damage is rare, but transient injuries or irritation can happen.
Which nerves are most at risk?
It depends a bit on the procedure. With the Letarjet, because the dissection is near the coracoid process, the musculocutaneous nerve is most commonly cited as being at risk. Some reports mention it in up to 30% of nerve complications, though actual lasting weakness is much less frequent. The axillary nerve, which runs around the back and side of the shoulder, is also vulnerable, especially during screw placement or if extensive dissection is needed. Maybe around 13% of nerve issues involve the axillary nerve. The suprascapular nerve can also be at risk during certain arthroscopic approaches.
So careful nerve monitoring is needed.
Careful technique during surgery and a thorough neurological exam after surgery are crucial. If a nerve deficit is found, especially if there's suspicion it might be due to misplaced hardware compressing the nerve, then urgent further investigation like a CT scan and potentially revision surgery to reposition or remove the hardware might be necessary.
Okay, nerves are one thing. What about stiffness? We touched on it with hyperlaxity, but is it a general risk?
Yes, stiffness, particularly loss of external rotation, is a well-recognized potential downside. It's that constant trade-off. Surgeons are trying to make the shoulder stable, which often involves tightening structures, but overdo it, and you sacrifice motion.
Which procedures are most likely to cause stiffness?
Some older open techniques that involved splitting or significantly tightening the subscapularis muscle were known for causing external rotation loss. Modern arthroscopic capsulification, used for laxity, intentionally tightens the capsule and can limit motion if not done judiciously. And the Litterjarget procedure, due to the anterior bone block and potential scarring, can also lead to some loss of external rotation. While small loss might be acceptable for improved stability, significant stiffness can be very disabling, so rehabilitation is key to manage this.
And infection. How common and serious is that?
Thankfully, deep infection after shoulder instability surgery is rare, probably less than 1% in most series, but when it happens, it's serious. Superficial wound infections might just need antibiotics, but a deep joint infection requires urgent surgical washout and debridement, plus a long course of antibiotics.
Does the hardware, like screws or anchors, complicate infection treatment?
It certainly can. If the infection involves the implants, particularly those holding a critical bone graft in place, you face a real dilemma. Removing the hardware might be necessary to clear the infection, but doing so could compromise the stability the surgery aimed to achieve. It requires very careful management.
Thinking even longer term now, we've mentioned osteoarthritis. Is there a specific link between having shoulder instability and developing arthritis later in life?
Yes, absolutely. The term used is dislocation arthropathy. This describes the osteoarthritis, the cartilage wear, joint space narrowing, bone spur formation that develops as a consequence of having had chronic or recurrent shoulder instability. And importantly, this can happen whether or not the shoulder was surgically stabilized.
So the instability itself damages the joint over time.
Precisely. The repeated episodes of the joint sliding partially or fully out of place, the abnormal forces across the cartilage, the damage from the initial injury and subsequent events, potentially subtle joint incongruity from bone loss. All these factors contribute to wearing down the joint surfaces over years.
Even if surgery successfully stops the dislocations.
Even then, the joint has already suffered insults. The surgery itself, while necessary, might also slightly alter joint mechanics. So while stabilization surgery is crucial to prevent further damage and improve function, it doesn't necessarily erase the increased long-term risk of developing arthropathy that comes with having had significant instability in the first place.
What does dislocation arthropathy mean for the patient?
Over time, it typically leads to increasing pain and stiffness. Ironically, the joint often becomes more stable as the arthritis progresses, but it's a stiff, painful stability. It can significantly limit function. And the data shows this isn't just theoretical. Studies looking at patients years after Bankart repairs, for example, show a clear increase in osteoarthritis rates compared to their preoperative state. Figures cited show rises from maybe 9% pre-op to nearly 20% at 6.5 years, or from 10% pre-op up to 60% in one study looking out over 13 years. It's a real long-term consequence.
That really hammers home the importance of managing instability effectively, and perhaps early, to protect the joint long term. Are there specific strategies recommended to try and prevent or at least minimize this risk of dislocation arthropathy?
Yes, the International Society of Arthroscopy, Knee Surgery, and Orthopedic Sports Medicine, ISAKOS, has put forward recommendations. A key one is trying to reduce the number of dislocations the patient experiences before surgery. This implies that earlier surgical intervention, rather than letting someone have multiple dislocations over years, might be protective for long-term joint health.
So don't wait too long if dislocations keep happening.
That's the suggestion. Other recommendations include meticulously assessing all the existing damage, bone loss, cartilage damage, pre-existing arthritis before deciding on and performing the surgery, as this informs the best procedure and prognosis. And for soft tissue repairs, ensuring really accurate anchor placement right on the glenoid rim and secure fixation is emphasized to minimize the chance of early failure, recurrence, and the subsequent joint damage that follows. The underlying theme is controlling the instability effectively and managing the bony architecture properly.
Makes sense. Okay, one last area before we wrap up, getting back to activity, especially for athletes. What's the typical journey after these surgeries?
The rehabilitation and return to sport discussion is often complex, particularly for athletes. There's that fundamental trade-off we touched on earlier.
Non-operative versus operative?
Yes. Trying non-operative management, mainly physio, might allow a quicker return to play, possibly even within the same season for some. But it comes with a significantly higher risk of the shoulder dislocating again.
Where is surgery?
Surgery almost always means the athlete is out for the remainder of that season. Recovery typically takes a minimum of 5-6 months, sometimes longer depending on the procedure in the sport. However, the major benefit is a much, much lower rate of recurrence in the long run, and therefore a higher chance of a durable return to sport.
That must be an incredibly difficult conversation and decision for a young athlete focused on their current season or scholarship prospects.
It is one of the toughest decisions in sports medicine. The discussion has to be very comprehensive. You need to consider the athlete's specific history. How many times is it dislocated? What level do they play at? Then the physical exam findings, detailed imaging like CT and MRI to see the extent of the damage, especially bone loss. And then layer on the timing factors. Where are they in their season? Are championships coming up? Are they trying to get recruited? Attempting to push through a season non-operatively is often seen as a very high-risk gamble.
Once the decision for surgery is made, what does the rehab process generally involve? Is it similar for different procedures?
The underlying principles of rehab are similar, whether it was non-operative or post-operative treatment you need to restore range of motion, rebuild strength, improve neuromuscular control and proprioception, and then gradually reintroduce sport-specific movements. However, the timeline and specific restrictions vary hugely depending on the surgery performed.
How so?
Bony procedures like Latarjet or significant bone grafting usually require longer periods of protection, perhaps limited weight bearing or stricter range of motion restrictions initially to allow the bone to heal properly compared to a standard soft tissue Bankart repair. Adhering to the specific protocol for the procedure done is critical.
And deciding when someone is actually ready to go back to playing their sport, is it just based on time?
Time-based criteria, like saying, okay, it's been 6 months, are still commonly used as a general guideline. But there's a strong shift towards incorporating more objective functional testing alongside clinical assessment.
Objective tests like what?
Things like measuring strength using isokinetic machines, assessing upper body endurance and stability with tests like the closed kinetic chain, upper extremity stability, CKCUES test, or evaluating balance and proprioception using something like the Y-balance test. These provide measurable data points.
So moving beyond just how does it feel to what can it actually do?
Exactly. These objective tests help the medical team, the athlete, and the coach make a more informed, evidence-based decision about whether the shoulder is truly ready to withstand the demands of their sport without an unacceptably high risk of re-injury. It helps take some of the guesswork out of that crucial return-to-play decision.
That makes so much sense. Right, wow, we have covered an enormous amount of detail there. We started with basic stability, explored the huge impact of bone loss, dived into advanced surgeries like remplissage, grafting, Latarjet, looked at tricky patient groups, faced complications and revision surgery, and considered the long-term health of the joint right through to recovery. Let's try and crystallize some of that with a quick lightning round. Ready?
Let's do it.
Okay, question 1. In a healthy shoulder, what are the two main ways it stays stable in the mid-range of motion?
Negative intra-articular pressure and the concavity compression effect from the muscles.
Spot on. Question 2. What concept is key to understanding if a Hill-Sachs lesion is problematic, looking beyond just its physical size?
The glenoid tract concept, whether the lesion engages the glenoid rim.
Perfect. Question 3. If there's significant bone loss from the glenoid socket, what are the two main surgical strategies used to replace that missing bone?
Bone grafting, using either autograft or allograft, and the Latarjet procedure.
Excellent. And final lightning question. What's the potential long-term consequence for the joint surfaces resulting from recurrent shoulder instability, even if it's treated?
That would be dislocation arthropathy, which is essentially progressive osteoarthritis.
Fantastic. Great summary points. So let's try and pull together maybe 5 key actionable takeaways from this really in-depth discussion on complex shoulder instability. 1. Remember that recurrent shoulder instability is very often more than just a ligament tear. Bone loss on both the socket and the ball is incredibly common and absolutely critical to assess properly.
Couldn't agree more. Assessment is key.
2. When looking at a Hill-Sachs lesion, don't just measure its size. Use the glenoid tract concept to determine if it's likely to engage the glenoid rim. That's what really drives instability risk from the HSL.
Engagement is the crucial factor.
3. If significant bone loss or specific patient risk factors mean a simple soft tissue repair isn't enough or is likely to fail, then advanced techniques like remplissage, bone grafting, or the Latarjet procedure become necessary. Each has specific indications, benefits, and potential drawbacks.
Matching the procedure to the specific pathology and patient is vital.
4. Patient-specific factors matter hugely. Age, activity level, especially collision sports, the number of previous dislocations, and any underlying conditions like epilepsy or hyperlaxity significantly influence the risk and the post-treatment plan. It cannot be a one-size-fits-all approach.
Absolutely. Personalized medicine is essential here.
And 5. While modern surgery can do a fantastic job of improving stability and getting people back to activity, it's not without risks like stiffness, nerve issues, or infection. And critically, the history of instability itself carries a long-term risk of joint degeneration dislocation arthropathy. This really underscores the importance of timely, effective treatment and thorough rehabilitation.
Well summarized. The goal is stability now, but also preserving joint health for the future.
Precisely. Now, if you listening found these insights as valuable as I did, perhaps consider rating and sharing this deep dive on your professional networks, maybe LinkedIn or X. It genuinely helps others find and benefit from these important conversations.
Hearing different perspectives is always useful.
Absolutely. And that leaves us with a final thought to mull over. Given the potential for serious long-term joint damage and the complex trade-offs involved in treatment, especially for young, very active people, how do we truly strike the right balance? How do we best weigh that immediate, often intense desire for a rapid return to sport against the arguably more important goal of preserving the long-term health and function of the shoulder joint? How can surgeons, patients, families, coaches all collaborate effectively to navigate those potentially competing priorities?
That is the million-dollar question, isn't it? A challenge we face every day.